Okay, welcome back to the afternoon session. We're now going to go on to rabies vaccine with an introduction by Dr. Fry. Dr. Fry, are you ready?
All right, so this is Sharon Fry presenting on behalf of the Rabies Work Group. Next slide, please. Oh, can you go back one slide? Where is the work group member slide? I guess that disappeared. Okay, in October, we introduced the Rabies Working Group. That was of 2018, and during October 2019 and February 20th, we presented the following: a review of vaccine safety and the work group considerations for changes to the PrEP series, as well as a systematic review of published literature about primary immunogenicity and the duration of immunogenicity of the intramuscular 07 days PrEP series using the human diploid cell vaccine and the purified chick embryo cell vaccine. And we also gathered feedback from the committee about the data needed in order to consider shortening the PrEP series from intramuscular 0, 7, 21, or 28 days to the intramuscular 0 and 7 day series. Next slide, please. Okay, so our focus continues to be based on the fact that rabies is nearly always fatal, and no proposed change should be considered if inferior to the current intramuscular 07, 21/28 day series. We considered improvements to the current PrEP recommendations that are supported by robust data, enable an anamnestic response for the duration of the recipient's life, and are based on what is known about the compliance, acceptability, and reasons for current guidance. Next slide, please. I think my slides have gotten out of order. Okay, so our activities related to the PrEP include comprehensive re-review of PrEP in context of the committee's feedback. We review the purpose of PrEP and expectations for the data if changes are proposed. We delivered our policy questions that can be confidently proposed that are thought to be an improvement from the current recommendations and grounded in data. And we leveraged the working group rabies subject matter expertise in immunology, historical basis of current recommendations, travel medicine, clinical practice, public health, veterinary medicine, and considerations made by WHO in the 2018 update of PrEP recommendations. And we also completed GRADE and ETR framework for 2 policy questions. We did talk about rabies RIG products. However, we're not going to be talking about that today. So next slide, please. The working group faced a number of challenges during our deliberations, which include the following. Some of the previous recommendations were based on expert opinion, and current recommendations, some of them are legacy from an extremely conservative approach to less optimal rabies vaccines. We had there's limited data that exists to modify recommendations thought to be excessive. There are diverse recipients of PrEP, including research laboratorians, bat biologists, veterinarians, animal control experts, spelunkers, and travelers to canine rabies endemic countries. So it becomes difficult to create a one-size-fits-all recommendation given the differing types and levels of risks of these populations. And lastly, compliance to the current ACIP recommendations has been of concern, and examples of this are that many veterinarians are known to be non-compliant with titer checks, and also PrEP is not covered by the employer or insurance for many of the professions. Next slide, please. Today, the goals are to present the product of the working group deliberations and obtain further feedback and discussion from the committee, also to answer tough questions and determine whether the proposed policy questions can be voted on during the February meeting. Next slide. Today's agenda will include the following presentations. Background review and summary of the working group considerations presented by Dr. Agam Rao. Minimum antibody titer and implications on ACIP recommendations presented by Susan Moore. Fundamentals of rabies immunology presented by Dr. Deborah Briggs. After the break, Dr. Rao will present the following 3 topics: review of the policy questions, a systematic review of the PrEP schedule, and a presentation of GRADE, evidence to recommend framework, and titer frequencies, summary, and next steps. Next slide, please. Okay, so I would like to acknowledge Lynn Bader, who is an ACIP committee member, and all the working group members for their significant contributions. I would especially like to thank our CDC leads, Dr. Agam Rao and Jesse Blanton, who have done a tremendous amount of work on this committee, and also give a special thanks to our invited consultants. You will actually hear from 2 of them today, but their knowledge base has just been incredibly invaluable to this committee. Thank you. Next slide.
Thank you very much for that presentation, Dr. Fry. We'll begin now with a background by Dr. Rao.
Thank you. Human rabies is an acute progressive encephalomyelitis that is nearly always fatal. It's transmitted from infected mammals, and worldwide, dogs are the most common cause, with 59,000 human cases of rabies occurring worldwide each year. In the United States, bats are the most common cause, and canine rabies virus variant, or RVV, has been eliminated ever since 2007 here in the United States. There are only 0 to 4 human cases per year in the U.S. One of the reasons there are few cases in the U.S. is the information on this slide. The figure shows years on the x-axis and animal cases on the y-axis. You can see that over time, rabid domestic animals, that is livestock, cows, and dogs, has decreased, as shown on the bottom curve, because of various implemented measures. During the same time, for multiple reasons, rabies among wild animals has increased, as shown in the top green line. But there's still a lot of potential for human rabies in the United States. There are approximately 5,000 animals testing positive for rabies each year. Mammal reservoirs vary by geography. Terrestrial or wildlife rabies is the RVV for which wildlife are the reservoir, and non-terrestrial rabies is the RVV for which bats are the only reservoir. Terrestrial rabies is restricted to specific U.S. regions, and the figure on your right actually shows those regions. And the exact outline for those regions can change on an annual basis, but you can see that in general it's kept to specific regions within the country. Certain variants like raccoon rabies variant is shown on the right side of the screen, different from what you might experience on some of the western states like Oregon and Washington State, where only bats are a reservoir for rabies. The non-terrestrial rabies is in every state in the U.S. except for Hawaii. Hawaii is the only state in the U.S. that is rabies-free. So there are multiple factors that contribute to the incidence of human rabies cases. Behaviors like avoidance of trying to pet wild animals is something that you'd think is obvious, but it's not always followed. In addition to behavioral issues, animal vaccinations affects whether or not human rabies cases, pets are vaccinated, and also through many efforts nationwide with USDA, wildlife is vaccinated through oral baits. Education and training, there's been a lot of focus on. There's awareness of the need to seek medical care if bites or scratches occur, and then training for proper use of personal protective equipment if handling bats or working in a laboratory are all opportunities to prevent rabies from occurring. And then post-exposure prophylaxis, if there is an exposure despite all of these. And then there's also pre-exposure prophylaxis, which I'll explain more about a few slides from now. For the general U.S. population, if a rabies exposure is going to occur, it occurs during occupational or recreational activities inside the United States. If it is a recognized exposure, which is a very important concept that I'll be referring to many times during today's presentation, by recognized, we mean that it is a bite or a scratch, for example, from a raccoon, a mongoose, or a fox that has rabies. So it's an exposure that any person with intact mental status would realize that they had and would seek medical attention and post-exposure prophylaxis or PEP to. It's not one that would go unnoticed, and that's the type of exposure that the general U.S. population would be at risk for. Pre-exposure prophylaxis is not advantageous for the general U.S. population and has never been recommended by ACIP for the general U.S. population. As a side note, it is expensive and typically not covered by insurance. This slide explains an important point that it is important to keep in mind during today's session. Rabies Prep is not a substitute for PEP. Anyone who gets PrEP should still get PEP if he or she has an exposure. The current vaccine series for healthy persons who have an exposure is, in the case of people who receive pre-exposure prophylaxis, 5 total vaccines and no rabies immunoglobulin, or RIG. And for someone who did not receive PrEP, 4 vaccine doses and RIG are given as PEP after an exposure occurs. You can see that PrEP isn't a substitute for PEP, and someone who gets PrEP actually ends up getting more total vaccines if you count the number of vaccines given as part of PrEP. The benefits of PrEP are that it eliminates the need for RIG, which is expensive and may not be easily available during, for example, international travel. It shortens the PEP series for persons who may have multiple rabies exposures in their lifetime, and it provides some protective coverage if a delay in PEP administration could occur, or if the exposure type is the sort that only laboratorians have, for example, with high concentration of rabies virus. Rabies risks that warrant PrEP are higher than those of the general population and include the 4 bullets on this slide. Persons should receive PrEP if they have any of the following: an unrecognized exposure, and by that we mean an exposure that a person with intact mental status may not notice, and so PEP is not sought. They have potential for exposure to high-potency virus or unusual exposures. By this, we mean the high concentration or research-grade rabies virus, aerosolized rabies virus, or non-rabies lyssaviruses, all of which are only potential exposures for laboratorians. Third, opportunities for frequent contact with potentially rabid mammals, for example, because of their job or recreational activity as a bat biologist or as a spelunker. And then travel to canine rabies endemic countries where they may not have easy access to post-exposure prophylaxis, particularly if they are going to a very rural part of a country and RIG is only accessible in the capital. The work group organized the information from the previous slide into the 3 risk groups on this slide. So laboratorians are the persons who frequently handle bats or enter environments with high concentrations of bats, like bat biologists and some pest control workers. And then persons who work with animals, for example, wildlife workers and veterinarians, or people who may come in contact with dogs in canine rabies endemic countries. Laboratorians have a high potency or unusual exposures. They also have unrecognized exposures and frequent contact with potentially rabid mammals. So you can see that there are several reasons why they would be on the list for receiving pre-exposure prophylaxis. In the second group, the people who frequently handle bats, they can have unrecognized exposures, and they can also have frequent contact with potentially rabid mammals. So again, they too have more risks than the general population. And then persons who frequently work with work with mammals other than bats, like wildlife workers and people who come into contact with dogs when they travel abroad, they have frequent opportunities for recognized exposure, and so they still have one risk that is more than that of the general population. So what this shows is that these 3 different groups, as you go up on the slide, there's increasing risk for rabies. And I want to talk a little bit more about these 2 particular groups in the next few slides. So recognized exposures are, again, those that a healthy person with intact mental status would know they had. On the top of this slide are exposures from terrestrial mammals. The tooth size is 15 to 50 millimeters, and the bite strength can be as much as 320 pounds of pressure. So it would be hard to not know that you're bitten by an animal. It would not have an unrecognized exposure. Now, on the bottom of the slide is exposure from bats. The tooth size is 2 to 10 millimeters, and bite strength is only about 2 pounds of pressure. For the vast majority of people, that is still going to be a recognized exposure. But for example, if you're swarmed by a cave full of bats because you're entering a bat cave as a biologist, you may not know whether or not you had an exposure. And so it's this population of people that we're referring to when we put people who frequently handle or enter environments with high density of bats into their own category, separate from the general population. This is a table from the current ACIP rabies recommendations. I just want to walk you through the important features of this table. Pre-exposure recommendations, including schedules and frequency of titer checks, are listed in the last column here. But those are different depending on risk level, which is the first column. For example, at the bottom of the first column is the risk category for the general population. And like we've said, that group has very little risk for rabies, and so there is no PrEP for the general population. But as you go up in the table, risk increases, and then the titles continuous, frequent, frequent, and infrequent that are listed in the first column correspond nearly completely, but not quite, to the 3 risk groups I showed on an earlier slide. But in general, it's the same concepts. On this table, the nature of risk is similar to what I presented. Those in the highest risk group are laboratorians who have recognized and unrecognized exposures and may be exposed to aerosol generating procedures and high concentrations of virus. Those in the second risk group have recognized and sometimes unrecognized risks, and those in the third risk group have only recognized risks. What is different, though, is the typical population column here, which is shown in the yellow box. You probably can't see the examples for the various populations because of the small type, but this section has been very confusing to clinicians and public health authorities. One of the confusing elements is that one group of laboratorians, the diagnostic laboratorians, are in the second risk group instead of up in the highest risk group with the other laboratorians. Travelers remain in the number 3 risk group, but what we decided is that we would move all laboratorians into the highest, most risk group, keep travelers where they are in the third risk group, and then regarding some of the occupations that are listed in both the second and third risk group, like veterinarians and people who deal with wildlife, they are in the 2008 ACIP recommendations listed in 2 different sections. But that is because at that time, the idea of them working in terrestrial versus non-terrestrial regions weighed heavily into the committee's decisions about how high their risk was. The work group, however, felt that the distinction was not needed for pre-exposure prophylaxis, and I will talk a little bit more about that later on. The thought was that for purposes of PrEP, your occupation is the most important factor. If you work in a terrestrial rabies region, you may, as a wildlife worker, have more opportunities for exposure to a rabid animal than your wildlife worker colleagues in a region without terrestrial rabies. But does the number of potential risks matter? And we concluded that for PrEP, no, it doesn't. There's more opportunities for exposure in terrestrial regions versus non-terrestrial regions if you're a veterinarian, for example, but the exposure type still remains a recognized exposure, and that's why we decided to group them into the same risk group. And so going back to this slide that I presented earlier, we believe that there's no reason for whether the work occurs in a terrestrial region versus a non-terrestrial region to figure into the risk categories for pre-exposure prophylaxis. And that is why we did not include them in the second list here, the second group here. So this is the revised table that the work group developed that shows the changes the work group made to the table after all of this discussion. For the purposes of removing any confusion about the previously titled continuous, frequent, and infrequent risk groups, we are labeling them as number 1, number 2, and number 3 risk groups. The differences in the typical populations and the fact that terrestrial and non-terrestrial regions does not figure into the decisions is clear from these 2 columns. And what we're left to fill out are the last 2 columns of the table. Our goal for primary immunogenicity was to identify the same series for all 3 risk groups. That will result in the least amount of confusion if there's a single series that all 3 risk groups can use. And then our goal for long-term immunogenicity is a bit more complicated. Since those in the number 1 and number 2 risk groups have risk for unrecognized exposures, our goal for long-term immunogenicity is different from those in the number 3 risk group. Those with unrecognized exposures should have titers persistently found to be over the minimum acceptable antibody cutoff in the event that they have an unrecognized exposure and do not seek PEP. And then the goal for those in the number 3 risk group for long-term immunogenicity is different, though. It is to ensure that if an exposure occurs 20 years later or however long after PrEP was completed, the person will still have an anamnestic response to an exposure. If they can't be guaranteed to be previously immunized 20 years after completion of PrEP, we cannot give them the shortened PEP series that is typically given to someone who received PrEP. And that's why ensuring that any series will ensure long-term immunogenicity is important. The last 3 presentations today will provide information that fills in the work group's preferences for these 2 columns, primary immunogenicity and long-term immunogenicity. The next 2 presentations will provide more background information before we can fill in those last 2 columns. First, we have a presentation about minimum acceptable rabies antibody titer and implications on ACIP recommendations. The purpose of this talk is to share problems with the current ACIP cutoff titer and propose a solution and outline the potential implications of the proposed change. And then the other presentation is about pertinent fundamentals of rabies immunology. And the purpose is to show how efficacious the current vaccines used for rabies are. ACIP recommends only intramuscular use of rabies vaccines for several reasons, and we're not proposing a change to that, but intradermal is used more worldwide because of the cost savings associated with ID administration. And because there's so much international data for ID, a second purpose of Dr. Briggs's presentation is to show why the work group feels that ID data can be used to inform decisions about IM administration. And you'll see it'll also make sense why we included in the grade presentation later today ID data. And then finally, during the February ACIP meeting many months ago, the committee pointed out various things that will weigh into their decision to vote for or against any changes to the current ACIP recommendations. They said that the 2008 ACIP recommendations have been effective. Rabies is nearly 100% fatal. Any proposed changes need to be supported by robust data, address the evolving rabies landscape, reflect new data, and increased confidence in modern cell culture vaccines, and not have suboptimal immunogenicity to current PrEP. They also pointed out that WHO and ACIP recommendations do not have to align. Dose and cost-bearing options were a top priority for WHO, but not necessarily for the US population. So all of the proposals we are making today are with all of these points in mind. And with that, I can take any questions, and after that, turn it over to our 2 work group members to provide more background.
We're open for questions from the voting members. I'm not seeing any from the liaisons. Okay, we'll move on to the next presentation. So next will be Dr. Susan Moore, who will talk about the minimal acceptable rabies antibody titer and implications on ACIP recommendations. Dr. Moore, are you ready?
I am. Can you hear me?
We can. Go forward.
Thank you for the opportunity to speak to you about minimum acceptable rabies antibody level. As part of my presentation, I'm going to present the rationale and history of the minimal antibody level and technical issues related to the testing and reporting of this level to explain the proposal for changing the minimal rabies antibody level to 0.5 IU per ml. So to start, as Dr. Rao presented, pre-exposure prophylaxis, or PrEP, is not indicated for the general population. It is indicated for persons who are at risk for unrecognized exposure to rabies virus, work with high potency rabies virus, and may have an unusual exposure to rabies, such as aerosolized exposure, or frequently are in contact with potentially rabid mammals, such as a wildlife biologist, or travel to canine rabies endemic regions where they may be at risk of delayed post-exposure prophylaxis if rabies exposure occurs. The minimum acceptable antibody level is the target level for primary immunogenicity 2 to 4 weeks after completion of a primary pre-exposure vaccination schedule. And it's the target level at the intervals for which antibody level checks are recommended. Next slide, please. So this is the slide that Dr. Rao presented in the previous presentation. The red box is the column where the primary vaccination series will be, and the blue box is the column where the frequency of antibody level checks will be indicated at each risk group. So for the future presentations today, when the work group's proposed recommendations are presented, at the back of your mind, you may wonder what impact those recommendations may have if the minimum acceptable antibody level is set at one value versus another. Next slide, please. As introduction, I want to first establish why we care about the minimum level and how it is important to us. We use the level as an indication of successful primary pre-exposure vaccination series, and it's used to monitor for evidence of immunity. The reason I'm talking about it here is that the current antibody level, as stated in the ACIP recommendations, is confusing and difficult to interpret. Next slide, please. To emphasize my last point in the last slide, I show here what is posted on the Kansas State University Rabies Laboratory website to aid clients in interpretation of rabies serology results. And you can see part of it there on the right side. I wrote this years ago in response to the many questions KSU Rabies Lab received on the reported results in relation to what the ACIP says. KSU is one of 3 places that perform rabies serology testing on human samples for the public, and much time and effort is spent in explaining how the reported results relate to the ACIP minimal acceptance level for antibody. And I can tell you, in my years of directing the KSU laboratory, this has been a major issue for reporting results. And for a fatal disease such as rabies, the recommendations need to be crystal clear. Next slide, please. To understand the cutoff levels, I want to first talk about what is known about immune response to rabies infection and the role of vaccination in protection, particularly the significance of neutralizing antibodies. Rabies is well known to be 100% fatal. It is primarily due to the poor immunological response to infection. But we also know it's nearly 100% preventable through pre and post-exposure vaccination. Its high circulating antibody targeting the glycoprotein of the virus has been proven to be the most important component of immunity to rabies. And for obvious reasons, no efficacy studies have been performed in human subjects for determination of the antibody level required for rabies protection. So we look to animal rabies vaccine challenge studies for surrogate data. In animal vaccine studies, some animals with low levels of antibody pre-challenge succumb to that challenge. Conversely, some with no detectable antibody pre-challenge survive. So there's no definitive titer known to be universally protective. Next slide, please. One of the first studies to look at the level of antibody associated with survival in animals was published in 1984 by Bunn and Ridpath. They used statistical methods to calculate the probability of survival from pre-challenge titers, concluding that at a level of 0.2 IU per ml, the probability of survival was 95%. And then at 0.5, it was 99%. Please note that I give the test results in two ways, titer value and IU per ml, as I will address this issue later. Other subsequent publications of summary studies in dogs, cats, ferrets, and wildlife gave similar results regarding the practical significance of rabies antibodies. These papers also commented strongly on the variability of the test method and the need for standardization in testing. In animals, the level of 0.5 IU per ml is robustly associated with survival and is the level used to verify adequate rabies immunity in pets traveling to rabies-free areas in the world. In addition, though there is no absolute antibody level indicator, the level 0.5 IU per ml is the consensual criterion for immunogenicity in rabies vaccine evaluation. Next slide, please. So the minimum level of rabies virus neutralizing antibody, or RVNA, is determined for humans when they determined it was based on results of early vaccine clinical trials where the rabies serology data came from either the mouse neutralization test or the rapid fluorescent focus inhibition test, or the RFIT. RFIT results are reported in terms of the 50% endpoint titer and or in IU per ml. Both the WHO and ACIP use the same rationale in setting this cutoff level, which was by evaluating the data to determine the minimal antibody level robustly associated with the detection of specific RVNA. The WHO and ACIP cutoff levels are different and are expressed in different ways. The WHO cutoff, which is 0.5 IU per ml, is approximately 5 times higher than the ACIP cutoff. The ACIP states the cutoff level as a description, and this is a quote from the current recommendations: complete neutralization at a 1 to 5 serum dilution by the rapid fluorescent focus inhibition test. This loosely converts to anywhere from 0.1 to 0.3 IU per ml. And although there are no cases of rabies that have occurred in the United States using this cutoff, this fact is misleading because many factors contribute to survival. The ACIP recommendations also state that rabies serology results be reported in IU per ml values, but it does not give the relationship of the recommended level to the reported values. So the ACIP cutoff it's neither a titer value and it's not an IU per ml value. Next slide, please. So this chart displays the history of published recommendations from both WHO and ACIP regarding the level of RVNA representing an adequate antibody response and the laboratory methods recommended to measure the antibodies. WHO has consistently recommended 0.5 IU per ml. ACIP has recommended using the RFIT consistently, but has expressed the cutoff level variously and at times in unclear terms. In 1984 and 1991, 2 different levels were recommended for different situations. In 1999, the level was expressed again in a description of the reaction microscopically read on the RFIT slide, the complete neutralization at a 1 to 5 serum dilution. So unless you have performed the assay, you have no reason to know that the calculation of a result of a complete neutralization at a 1 to 5 serum dilution is actually a titer of 1 to 11. So the ACIP cutoff is confusing and hard to interpret for determination of a need for booster. Next slide, please. So as I mentioned, the test used for rabies serology is the RFIT and can be reported in either titer or IU per ml, or both. And I want to briefly explain what is actually a complex series of steps for testing and reporting rabies serology results. A titer is the serum sample dilution that neutralizes a standard dose of live rabies virus. Titer values are variable due to the inherent variability in cell-based serum neutralization methods. For anyone who has worked in a serology or a virology laboratory, you know that not all factors that affect a biological interaction, such as antibody neutralizing a virus or virus infecting a cell, can be exactly controlled over the course of the interaction. Ranges are given in the lab methods for pH, temperature, incubation times, etc., to attempt to control the conditions, but there are many factors beyond these that can influence variability. This variability occurs within the same lab between each time the test is run and between laboratories. Titer values will vary between testing events. This is a given. However, the reference serum, which is a known positive rVNA control, will vary in the testing event similarly as any other sample tested at the same time. And we use this fact to standardize the titer value into international units. On the next slide, I will show you how this is accomplished. Next slide. Here I show the steps to calculate first the titer and then convert the titer to IU per ml. The RIFIT readout using a microscope is a count of the virus positive fields on a slide out of 20 total fields. This count is entered into the Reed and Munch formula, which gives us the 50% endpoint titer value. The formula for the conversion of titer to IU per ml is simpler. By just taking the sample titer, dividing it by the reference serum titer, and then multiplying by the potency of the reference serum in IU per ml. And per the WHO lab manual for rabies, in the RIFIT, the reference serum is tested at a potency of 2 IU per ml. So as in this example, a sample serum titer of 50 is divided by the reference serum titer of 200, multiplied by the potency of the reference serum, which is 2 IU per ml, and that gives us the value of 0.5 IU per ml for that sample. There is no direct correlation between titer and IU because of the RIFIT variability I previously mentioned. However, in most labs using internationally recognized RIFIT protocols, the ACIP cutoff, remember this is a titer of 1 to 11, is in the range of 0.1 to 0.3 IU per ml. So in summary, rabies serology testing and reporting is all very complicated, but the main point being the ACIP cutoff level is hard to correlate directly to the associated titer value, and that there is a range of IU per ml values that can be associated with it. Next slide, please. And I want to show you how this works in real life, and we'll take some time on this slide to explain the complexity of the testing. So one of the variability factors in the RIFIT is the virus dose. Per the WHO lab manual for rabies, the virus acceptance range is 30 to 100 TCID50 with a target of 50 TCID50. So here we have 3 labs, A, B, and C. Lab A actually uses a virus dose below the range. Lab B uses a virus dose near the target, and Lab C uses the highest virus dose. In each test, each of those laboratories test the same samples from Mary and John, as well as the same control sera, the reference sera, which serves as a positive control, and the negative, and then also a negative control. You can see how the titer values vary between the laboratories. The titer values, all the titer values, the samples in the control sera, decrease as the virus dose increases, yet the calculated IU per ml values remain the same. This shows that IU per ml values are less variable than the titer values. So conversion of IU per ml controls for the variability of the test. Now, staying on the same slide, we look at the results of these three labs, and we can see how the titer results from labs B and C end up recommending booster vaccination for Mary following the ACIP cutoff. However, all three of the labs' IU per ml results using the WHO level indicate a booster vaccination for her. So they all agree, all the IU per ml values point to the same decision. And this is the same for John. There's a discrepancy of booster decision when using the titer results, but not when using the IU per ml results. So then we can conclude normal variability in laboratory testing of the RIFID can lead to an incorrect interpretation of antibody levels if you do not standardize the titer into international units. Next slide, please. For serum neutralization assays, anything that inhibits virus infection or growth will cause non-specific neutralization reactions. The ACIP cutoff is actually very near the lower limit of quantitation of the assay in most laboratories. This table shows the percent of samples from unvaccinated subjects that produce a positive rDNA result in the RIFID depending on the cutoff. The percentage of non-specific neutralization results or false positives increases the lower the cutoff level is set, introducing some uncertainty and accuracy at this level. And for a disease, again, that's 100% fatal, the cutoff level should ensure minimal false positives. Next slide, please. So on this slide, I have a summary of results displayed here from a number of rabies antibody monitoring events at veterinary conferences and veterinary schools over several years. In purple shading are the percentages of people with results above the 0.5 cutoff, and then also the percent of people with results above the ACIP cutoff. Using these percentages, the percent of people that would need a booster based on the two different cutoffs are calculated, and they are in the yellow shaded columns. And then in the pink shaded column, you can see the effect of changing the cutoff to 0.5 given n-fold increase and how that affects the number of people recommended to receive booster vaccination. So overall, there's a 2.5-fold increase in people recommended to receive booster if the acceptable level changes to 0.5 IU per ml. Next slide, please. So in summary, an antibody level of 0.5 IU per ml is a better alternative to the current ACIP cutoff for defining the minimal antibody response to vaccination for the following reasons. Repeatedly in published animal studies, 0.5 IU per ml is robustly associated with survival from challenge. And the 0.5 level is the rDNA level that assures minimal false positives in the RIFID. In addition, using a standardized unit of measure, IU per ml, it provides us with results that are more accurate and precise than titer values. And it's the globally used unit of measurement for rabies serology, and is also the primary unit of measurement used in the United States. So next slide. So just to go over the clear advantages of the proposal to change the cutoff from complete neutralization of 1 to 5 serum dilution to 0.5 IU per ml, they are reducing confusion in interpretation for those at risk of this high stakes infection, increase in result precision and accuracy, decrease in risk of reporting false positive results, and it's a unit that controls for the inherent variability of the RIFID. The disadvantage is that there is a real potential that more people would be recommended to receive a booster vaccination. And that's the conclusion of my talk. I have the references that I used on the next slide. Thank you.
Thank you for that excellent presentation. let me see if there are any questions at this time, because that's a lot of information given to the group. My personal comment on this is that this was an outstanding presentation, and I think it really provides us with a good basis for making a decision regarding that particular change. So let me check and see if there are any questions. Let me pull up my screen. Yes, Dr. Hunter, please go forward.
Thanks. Great presentation. Very clear that seems pretty obvious that we should follow the sort of an international standard and have clear wording. I'm just putting on a hat of an occupational medicine physician or staff person, nurse at a some institution or lab or whatever that's dealing with people that are having the titers drawn. And I'm just curious how often if you have any numbers to say with the effective increase from, I don't know, 0.25 to 0.50, whatever, increase it really is of a million international units per ml, how many more people or what percentage of people will turn out to need boosters? If you could quantitate that, I don't think that's going to change what you should make the cutoff as. I think it just may be something that we need to give to the clinicians that this is going to affect to increase their acceptance of the change.
Yeah, and that's a really good question. And I wanted to make note, I didn't make it in the talk, but because the ACIP says that rabies serology results should be reported in IU per ml, that was a quandary for us in the laboratory that when we were reporting it, because we were struggling with how to report it in IU per ml when it's not the cutoff's not given in that unit. So, and also the rabies laboratory at Kansas State University does global work. We ended up putting both the cutoffs on the reporting, and as you saw on the website, it's quite long, but it explains that. And we're talking to vet schools and veterinary conferences. We were very conservative as saying both that this WHO says 0.5, ACIP says this level, which is in our laboratories about a 0.1, 0.2. However, the 0.5 is a more conservative cutoff, and it seems like a lot of, especially schools and occupational groups go with the 0.5. I know in the laboratory I worked in, we went with the 0.5. So the actual increase in number of people getting a booster, if the ACIP says 0.5, I don't think is going to be a large number. Right. But yeah, it's hard to calculate.
That's very useful information to me. And I'm just wondering if there's a quick way to do a survey of the American veterinary medical schools or whatever, occupational health departments of those, that could help with the evidence to recommendations section of the acceptability. That would be great.
I agree.
Thanks, that's it for me.
Thank you, Dr. Hunter. I thought I saw another hand up. Anybody from the liaison group that would like to ask a question? Okay, I'm not seeing any further hands. All right, so let's go on to the next presentation. Thank you again, Dr. Moore. So our next presentation will be Pertinent Fundamentals of Rabies Immunology by Dr. Briggs. Dr. Briggs, are you ready?
Yes, can you hear me?
Yes, we can. Go forward.
Oh, excellent. Thank you very much for the invitation to speak about cell culture rabies vaccines and the fundamentals of rabies immunology. As part of my presentation, I'm going to present clinical data to show that the intramuscular and intradermal route of administration for cell culture rabies vaccines for both pre-exposure vaccination and post-exposure prophylaxis are equitable. Next slide, please. I'd like to actually begin my talk by discussing a brief history about the production of rabies vaccines and why there are two routes of administration, IM and ID. The first rabies vaccine was developed from infected nerve tissue by Louis Pasteur and his colleagues, as we all know, in the late 1800s, and various versions of nerve tissue vaccines were actually used globally through the 1900s and even into the 2000s. These vaccines required multiple doses to be administered into the abdominal region of the patient and over a lengthy period of time, and they caused serious adverse reactions. One of the first improved rabies vaccines was the duck embryo vaccine, developed in the 1960s, but it required 14 doses and produced low titers. Next slide, please. In 1976, the first field trial of human diploid cell rabies vaccine, HDCV, was endorsed by WHO, and it was conducted in Iran due to the number of rabies cases in the country and the fact that there was a reliable WHO reference laboratory in Tehran. In that first clinical trial, 45 patients severely bitten by a rabid wolf received HDCV, and 44 of those patients also received anti-rabies serum. One patient had been exposed to aerosol rabies only and was not given the anti-rabies serum. 6 doses of HDCV were administered subcutaneously, and all of those patients survived. This was actual proof that HDCV, the first generation cell culture rabies vaccine, was efficacious. In 1980, 2 important things happened. HDCV was licensed for IM use in the US, and the WHO experts met in Essen, Germany, and recommended a 6-dose intramuscular Essen regimen for post-exposure prophylaxis and a 3-dose intramuscular regimen for pre-exposure vaccination. At this meeting, WHO experts urged research into finding alternate routes of vaccine administration, including the intradermal route. And that was because the cost of PEP was so high using HDCV that they wanted a lower cost vaccine or route of administration so that they could encourage low-income countries to replace nerve tissue vaccines with cell culture vaccine. So in 1986, the US approved the intradermal administration of HDCV, prepackaged as a 0.1 ml dose, but it was taken off the market in 2001 due to the high cost of packaging that particular dose. From the late 1980s through the 2010s, clinical trials were conducted investigating the immunogenicity and efficacy of the intradermal route of the administration of HDCV, as well as newly developed cell culture rabies vaccines, including purified chick embryo cell vaccine, PCECV, and purified vero cell rabies vaccine, PVRV. And data from those trials proved that these vaccines were as effective as HDCV when administered either intramuscularly or intradermally in both pre and post-exposure regimens. Next slide, please. So in the following slides, we're going to take a closer look at the published data that the working group examined, comparing ID to IM in various clinical trials. The working group reviewed these data to determine whether data from ID administration studies could be used to inform recommendations for IM administration of cell culture rabies vaccines. We will also review efficacy data for cell culture rabies vaccines. Next slide, please. In order to evaluate the equivalence of the IM and ID route of administration, there are 3 basic factors that the working group needed to verify. These included confirming that the IM and ID route are equally efficacious, meaning that both routes will protect patients exposed to proven rabid animals, equally immunogenic, meaning that both routes will produce adequate levels of neutralizing antibodies in vaccinated individuals, in this case 0.5 international units per mil, and equally effective in eliciting an anamnestic response in previously vaccinated individuals when they receive a booster vaccination series. In other words, producing long-term immunity. Next slide, please. The very first study investigating the efficacy of post-exposure administered intradermally was conducted in Thailand by Dr. Phan Yufak and his colleagues at the Thai Red Cross. Their goal was to find a safe, effective, and inexpensive strategy to replace the crude nerve tissue vaccines that were being produced and used in Thailand, and to reduce the high cost of rabies deaths occurring in their country. The patients enrolled in this trial had experienced minor exposures to rabid animals. The cell culture the vaccine used was PVRV because it cost lower than HDCV. And the exposed patients were given one of 4 regimens. Group 1 received the full vial of vaccine administered intramuscularly on days 0, 3, 7, 14, and 28. Group 2 received 0.1 ml of vaccine administered intradermally at 4 sites. Group 3 received 0.1 ml of vaccine administered intradermally at 2 sites. And Group 4 received 0.1 ml of vaccine administered at 1 site on days 0, 3, and 7. So all of those ID vaccination regimens were given on day 0, 3, and 7. And then on day 28, those same ID groups received one more dose of 0.1 ml in the upper deltoid region. In this study, all patients survived. And this figure, taken directly from the publication of the data, shows that all patients, regardless of whether they received post-exposure via the ID or the IM route, developed neutralizing antibodies above 0.5 IU per ml by day 14. Their antibody levels remained above that 0.5 level through day 35, the last day that a blood sample was taken. Next slide, please. The Thai Red Cross wanted to do a confirmation study, a second efficacy study, and this was done in collaboration with CDC in Atlanta to confirm that the earlier study investigating the efficacy of the ID route for PEP worked. So in this study, they enrolled 100 patients that were actually severely bitten by confirmed rabid animals. Now, all the patients were followed for 1 year after vaccination. All of the patients received 2 ID doses of PVRV vaccine administered on each of days 0, 3, 7, and 1 dose was also administered on day 30 and day 90. This became known as the Thai Red Cross intradermal post-exposure regimen. All of these patients survived. And Table 1 shows you the type of bites that the patients had received and the expected mortality rate. As you can see, there most certainly would have been deaths due to rabies infection without the administration of intradermal post-exposure prophylaxis in these patients. As part of this clinical trial, blood was withdrawn in 10 patients during the study and titers checked on day 14, 90, and day 360. In Table 2, you can see that all titers remained above 0.5 IU per ml during the study. Over time, additional clinical data proved that the day 90 was not required, so that dose was dropped from the Thai Red Cross regimen, and further clinical studies and data have reduced the intradermal post-exposure prophylaxis regimen to the currently accepted WHO recommendation of a 1-week, 2-site schedule given on day 0, 3, and 7. Next slide, please. The immune response after pre-exposure vaccination by either IM or ID route has also been investigated in several clinical trials. This study shows the data from one of those studies and is representative of the clinical data that the working group looked over in many published studies looking at intradermal and intramuscular pre-exposure vaccination. This study was actually conducted in the US to confirm that the intradermal route of administration for pre-exposure was as immunogenic as the intramuscular route. It was done, to find reliable strategies for administering pre-exposure to those persons at greatest risk due to their occupation in the event of a human rabies vaccine shortage in the US, and shortages of human rabies vaccines had previously occurred. So 128 subjects were enrolled in this study, and the vaccine that was administered was PCECV. Subjects were randomly put into one of 4 groups. Group 1 and 2 had not received rabies vaccine previously, and Group 1 received 3 doses intradermally on days 0, 7, and 21, and Group 2 received 3 doses intramuscularly on days 0, 7, and 21. Group 3 and 4 were previously vaccinated, and in this study, they received 1 booster dose of vaccine administered either by the ID route, Group 3, or the IM route, Group 4, in order to confirm a rapid anamnestic response. And as the graph from this published paper shows, previously unvaccinated subjects in both the ID and the IM groups responded with equally high titers after vaccination. All subjects had a titers above 0.5 IU per ml by day 21. As has been reported in almost all published clinical study reports, the IM route of administration gives slightly higher titers than the ID group. The IM group is shown here as the top line with the empty circles on the solid line on the graph. However, the slightly lower titers that are produced in the intradermal group are not clinically significant. And on this graph, V plus a number actually refers to the number of days after the last dose of vaccine was given. And that was when the blood sample was drawn. So for example, V plus 14 means that the blood sample was taken 14 days after the last dose of vaccine was administered. Next slide, please. So this slide actually shows the numerical geometric mean titers of the subjects shown on the previous slide. As you can see, all subjects in both the intradermal and intramuscular pre-exposure groups had titers above 0.5 IU per ml by day 21, and all titers remained above that level through the end of the clinical trial. Next slide, please. So one of the most important reasons for administering pre-exposure vaccination to patients at risk of exposure to rabies is to eliminate the need for rabies immune globulin in the event of a future exposure, and to elicit a rapid anamnestic response in the patient after they receive booster vaccination. So this is a recent paper by Wang Siraj et al. And the study was conducted at the Thai Red Cross Institute using PVRV. Both Group A and B received a 2-dose pre-exposure regimen administered on day 0 and 21. Group A was given the intradermal series, the intradermal route of administration, and Group B received the series by the intramuscular route. As you can see, the GMTs of subjects in both Group A and B are well above 0.5 IU per ml by day 35. 1 year after this vaccine was given, the primary vaccination was administered, and prior to the booster series, you can see that the GMTs of the ID group was 0.35 IU per ml, and the GMT of the IM group was 0.76 international units per ml. On day 365, both groups received a 2-dose booster series of vaccine administered as 0.1 ml intradermally in one upper deltoid on each of day 0 and day 3. 14 days later, all subjects had had an anamnestic response to the booster series, and the GMT rose to well above the 0.5 international unit per ml level, again confirming that pre-exposure administered either intradermally or intramuscularly are immunogenic, and that an anamnestic response will occur when these patients receive a booster series of vaccine. As noted here, there was no significant difference between the GMT in the IM and the ID groups on day 369 after each group had received the booster series. An anamnestic response to booster in pre-vaccinated subject has also been confirmed in numerous other studies. Next slide, please. So, why do we need additional cell culture vaccines when the first one, HDCV, was so efficacious? Well, throughout the decades since the development of cell culture vaccines, there have been numerous clinical trials that have compared these cell culture vaccines that are manufactured according to the WHO pre-qualification standards. The reason is because HDCV is expensive to produce, and it's very expensive for patients to purchase. There are now other equally efficacious and less expensive cell culture rabies vaccines that have come into the market, including PCECV and PVRV. These less expensive vaccines have enabled millions of lives to be saved and have eliminated the use and the production and use of nerve tissue vaccine. Numerous clinical trials have been conducted and data published to confirm that these vaccines, when produced according to WHO pre-qualification standards, are efficacious, immunogenic, and will elicit a rapid and anamnestic response to booster. I've included data from 2 clinical trials out of numerous published studies to show you that these vaccines are equivalent in immunogenicity and efficacy. And you have seen from my previous slides that they also will produce an anamnestic response in previously vaccinated persons. So the graph in this slide displays immunogenicity data from a clinical trial conducted by Dr. Madhu Sadana et al. It shows the GMTs in patients after receiving the Thai Red Cross intradermal post-exposure regimen with either PCECV or PVRV. Blood was withdrawn on day 0 prior to vaccination and on days 14, 30, 90, and 180. And as you can see, the titers are equivalent for patients that receive PCECV or PVRV. Again, all titers above 0.5 IU per mil by day 14. Next slide, please. This paper compares PCECV to PVRV. It was conducted at 2 hospitals in Thailand by Dr. Vasi and her colleagues. There were 211 patients that were enrolled with category 2 and 3 wounds, and they were placed into 3 groups. Group 1 and 2 received the Thai Red Cross intradermal post-exposure regimen. Group 1 received it using PCECV, and Group 2 received it using PVRV. Group 3 received the SN5 dose intramuscular post-exposure prophylaxis regimen using PCECV. The figure shows the GMTs of all 3 groups. The 2 groups that received the Thai Red Cross intradermal PEP regimen using PCECV or PVRV are shown in the unbroken and long dashed lines. As you can see, they are almost exact. The group that received the SN5 dose intramuscular post-exposure regimen had slightly higher GMTs, as has been reported in numerous other studies for the IM route of administration. But again, this is not clinically significant. Next slide, please. After reviewing the data referenced in the slides I've shown you and numerous other peer-reviewed published papers, the working group concluded that regarding efficacy, intradermal and intramuscular post-exposure prophylaxis are equally efficacious in patients exposed to confirmed rabid animals. Regarding immunogenicity, ID and IM pre-exposure vaccination are both highly immunogenic routes of vaccination, with IM producing slightly higher titers in most clinical trials, but there's no known clinical relevance attributed to the increased immunogenicity with the IM route. Cell culture vaccines that meet WHO pre-qualification standards will produce equitable immunogenicity responses in both pre-exposure vaccination and post-exposure prophylaxis regimens when administered intramuscularly and intradermally. And regarding the anamnestic response, patients that receive pre-exposure administered intramuscularly or intradermally will both have a robust anamnestic response to booster vaccination when administered either by the IM or the ID route. So the working group interpretation from these data concluded that when using high-quality cell culture rabies vaccines, intramuscular and intradermal routes of administration are equivalent among 3 clinically relevant immunologic factors: efficacy, immunogenicity, and anamnestic response. Thank you very much. I have put my references at the end of the presentation if you want to look at them.
That concludes that presentation, and thank you very, very much, Dr. Briggs, for that outstanding presentation. I think it really does show that there is equivalence between the intradermal and intramuscular routes, and that there is equivalency between rabies vaccines derived from different sources and productions. So I'll turn this over to Dr. Fry to see if she has any questions. Dr. Fry. Dr. Fry? Are you there?
Can you hear me now?
Yes, I can.
Yes.
Sorry. I just wanted to take a moment again to thank Dr. Moore and Dr. Briggs for their excellent presentations, and also just let everybody know that they have worked very hard on this committee, and they have been bombarded with endless questions by committee members. And so thank you very much.
Dr. Sanchez.
Yes, Pablo Sanchez. No, that was a great great presentations. My question is that what are the data comparing the two IM versus intradermal in children specifically? Because I think at least the couple of the articles I saw were in adults, or at least over 18.
Yes, and most of the patients, well, 35 to 60% of the patients in Asia and in Africa are actually children. So in Asia, much of the vaccine given for post-exposure is given intradermally, and it is well tolerated in children. And certainly there's no problem with intramuscular in children as well. There is a study looking at malnutrition, giving vaccines to malnourished children, and they also responded very well to the vaccine. That was in India.
And whether it was intradermal.
I don't know if that one was intradermal. I can certainly look it up, but the intradermal that has been given in India, in Thailand, and in the Philippines, a large percentage, probably 50% on average of those patients are children, and those vaccines are given intradermally, and there's no problem.
Thank you.
Are there any other questions or comments from the voting members? Any questions or comments from the liaison representatives? I don't see any. Okay, so we're going to take a 10-minute break and then return for the final portion of the meeting for today. So we will all return at Eastern time 3:29. Sorry, 3:39, forgive me, 3:39. Thank you.